case of simple things that go wrong in our day-to-day practice. So I'm Dr. Nitin from Army Institute of Cardiothoracic Sciences. Just present a case of acute stent thrombosis and how we managed it. So we had a 56-year-old lady, diabetic, hypertensive, had a recent anterior MI about a week back, was thrombolized in outside hospital. Echo-wise, ejection fraction of around 40% with regional wall motion abnormality in the LAD territory. Angiography was done outside, showed single vessel disease, proximal was 80% and intermediate lesion in the mid LAD. It's taken up for a PCI to proximal osteoprox LAD. So as you can see the angiograms, the osteoprox, there is a long segment, about 70% lesion. Mid LAD, what I thought would be intermediate, so we went ahead with planned PCI to the osteoprox LAD, thinking that there is a healthy segment in between these two lesions, planned to land the stent somewhere here. Wired with a workhorse wire, dilated first with a semi-compliant balloon, then also prepared the bed with an angiosculpt, and osteoprox LAD was stented by 322 mm resolute and post-dilated again with a NC balloon. So angiographic result seemed to be fine. The mid LAD lesions at this point appeared to be a bit more significant, but did not relieve, thought that could be some spasm after the initial PCI. So patient was fine and didn't just left the patient like that and did not address the mid LAD lesion, because on the diagnostic angiogram it had not appeared initially very significant to me. So the patient was shifted back to ward. Unfortunately, 2 hours after the patient went to the CCU, had an episode of VF. Luckily for us, a good response by the team at the CCU, immediate DC cardioversion, wheeled back to the cath lab for a check angio. And the check angio, as you can see, the LAD stent shows some thrombus. The mid LAD lesion definitely appeared to be much more significant. Luckily, patient was hemodynamically stable, not on any inotropes, not in shock, not on a ventilator. God was kind for that. So since she was stable, did an OC to actually find out what had gone wrong. So as you can see, the OCT run, this is the healthy segment, and then as we come back, we come to the diseased mid LAD segment. Here you can see a significant lesion in the mid LAD. It's lipid rich and fibrotic also. So this was the mid LAD, and the length was around 30 millimeters from the previous stent. However, where the stent had landed, it was healthy. We can see the EL over here. There was no edge dissections. We can see some thrombus in the stent. There is expansion at the distal end of the stent is less, and there are some areas of malapposition in the stent. So after this knowledge that we gained on the OCT, this is the cross section where you can see the malapposed struts, and this is the tightest lumen area of around 1.83 at the mid LAD. So definitely significant, less than 1.98. So we decided to post dilate this stent and also do a overlapping stent up to the mid LAD. So post dilated with a 3.5. We covered the 334 resolute from the previous stent overlapping up to the mid LAD segment, post dilated with a 3.5 NC up to high pressures, and achieved a TIMI-3 flow. So post OCT run showed a well opposed stent, and there was expansion was 76, which was further dilated, and subsequently patient had good TIMI-3 flow. So just the initial question was on clopidogrel, as that is the routine antiplatelet strategy that we follow, do a DAPT of ecosprin and clopidogrel. But out of interest, we also got CYP2C9 mutation testing, which showed that she was an intermediate metabolizer, and we had already switched her over to ticagrelor after the stent thrombosis event. But maybe this was another add-on precipitant to what caused the stent thrombosis. So, acute stent thrombosis, as all of you know, can be catastrophic. It's a very setback. You've done an angioplasty, patient goes back and within 2 hours has an event in the ward. It's definitely a catastrophic event. OCT helps us to understand the pathology behind stent thrombosis, and maybe as a learning point, especially critical lesions like osteoporox LAD, I feel we have started using imaging much more, maybe as a post-run, if not for all cases. At least finish it off with an OCT to see that the result expansions are good, there are no malappositions. And clopidogrel resistance in Asians, it has been studied, various reports are there that the incidence is much more than what it is reported. It's an under-recognized enemy. How frequently do we need to test for it? Should our strategy of dual antiplatelet be with prasugrel or ticagrelor? These are still unanswered questions. We need more data for that. Thank you.